Ankle fractures case discussion. A 28-year-old male presents to the emergency department after twisting his ankle during a basketball game. He reports pain primarily over the anterior and lateral aspects of his ankle, along with swelling and difficulty bearing weight. On examination, swelling and tenderness are present over the anterior distal tibiofibular joint. Positive external rotation stress test and squeeze test indicate syndesmotic involvement. Radiographs show a widened tibiofibular clear space greater than 6 mm and medial clear space greater than 4 mm on a mortise view, with no associated fractures. The injury is diagnosed as a syndesmotic ankle sprain. Key considerations. Anatomy and function of the syndesmosis. Consists of the anterior inferior tibiofibular ligament, posterior inferior tibiofibular ligament, interosseous ligament, and interosseous membrane. Provides stability to the ankle mortise by maintaining the alignment of the distal tibia and fibula. Mechanism of injury. Often occurs due to an external rotation or hyperdorsiflexion force. Common in high-impact sports like basketball, football, or skiing. Radiological evaluation. X-rays assess tibiofibular and medial clear space widening. Stress radiographs or weight-bearing films may reveal instability. MRI, gold standard for diagnosing ligamentous injuries and evaluating associated soft tissue damage. Management. Non-operative, mild injuries with no instability having stable mortise can be treated with immobilization, rest, and gradual rehabilitation. Operative, required for syndesmotic instability or associated fractures, options include syndesmotic screw fixation or suture button devices. Complications. Chronic instability, pain, and post-traumatic arthritis if untreated or improperly managed. Possible Viva questions and answers. What is the syndesmosis, and why is it important? The syndesmosis is a fibrous joint that connects the distal tibia and fibula, stabilizing the ankle mortise during weight-bearing and motion. What are the key clinical tests for syndesmotic injury? Squeeze test. Compressing the tibia and fibula proximally elicits pain distally. External rotation stress test. Pain over the syndesmosis with externally rotating the foot while stabilizing the leg. What radiographic findings suggest syndesmotic injury? Widened tibiofibular clear space, greater than 6 mm. Increased medial clear space, greater than 4 mm. Loss of tibiofibular overlap, less than 10 mm on AP view. What is the role of MRI in syndesmotic injuries? MRI is the gold standard for evaluating ligament integrity, soft tissue damage, and associated injuries such as osteochondral lesions. When is surgical intervention indicated in syndesmotic injuries? Syndesmotic instability having mortise widening on stress X-rays or weight-bearing views. Associated fractures, for example posterior malleolus or fibula. What are the options for surgical management of syndesmotic injuries? Syndesmotic screw fixation aligns and stabilizes the distal tibia and fibula. Screws are usually removed post-healing to restore physiological motion. Suture button devices allow physiological movement while maintaining stability, reducing the need for hardware removal. How do you assess syndesmotic stability intraoperatively? Direct visualization under fluoroscopy with external rotation or dorsiflexion stress tests. What post-operative protocols are recommended for syndesmotic injuries? Immobilization in a boot for 4 to 6 weeks, followed by gradual weight-bearing and physical therapy focusing on strength, stability, and proprioception. What are the long-term complications of syndesmotic injuries? Chronic pain, instability, heterotopic ossification, and post-traumatic arthritis. How do syndesmotic injuries differ from lateral ankle sprains? Syndesmotic injuries involve higher pain and disability levels, take longer to heal, and may require surgical intervention if unstable.